Okay. Okay, sorry for the interruptions.
It's done. It's done. It's live.
Yeah, sorry for the interruptions. There was some issue with the internet speed, and a lot of users have come for a lot of users for the same thing. So we were here that we are going to merge the data of the CBCT as well as the patient, which we have scanned again. So now we have planned for the placement of the implant at position number 4647 and 3637. So once that is done, merger of the scans, now we take out the CBCT, we take the CBCT out and we do the virtual planning on the CBCT. With the virtual planning, with the yellow thing, what you can see above the implant is the space or width of the guide. And in the next one, you can see there is a green colored something like sleeve. There is a space for the sleeve, which is given on the guided surgery kit, a guided design. Sorry. Yeah, so guide design. Once there, we have confirmed the pre-OPG with planning that yes, this is gonna be my depth, this is gonna be my width of the implant, and I'm okay with that. The person will provide you the guide design. Now, this is how tooth-supported guide can be made. There are different ways to make the tooth-supported guide. There are different designs. A lot of designs are there, so you can choose any of them with the sleeve, without sleeve, open sleeve, anything is fine. We'll discuss that also. So we took the print of 3 guides. Now, why we need 3 different guides here? Because the kit what we are using does not allow you to use the same sleeve for all the drills. As in, like in the first print to the green one on the right extreme, that is the first kit, which is their first print, which is there. There we have a very small tiny hole for the access of the drill, right? So that is for the pilot drilling. Now next drill is only 3.3. You can see there is a 3.3 written on the drill. So that is for the 3.3 diameter. And then the next one is the 3.8 diameter. So this is how, if you have a kit which is having a number of sleeves more, we have to take more prints, and this will be more expensive for us. But the kit which are provided by the Dentium, by the Ostem, by the Noble Biocare, we don't need to change the sleeve. We don't need to take the print of lot many things. We can lot many guides. We can just have the one universal sleeve, and you are done. So next is the fitting of the guide. Always do check of the guide in patient's mouth, because sometimes the guide may be rocking, sometimes the guide may not fit in the place. We also prefer, if you have an enough CBCT, then you can just take the skin with the sleeves. The skin is the sleeves is the metal object. It will come, it will show the exact position of your implant. Next is the placement. We have 2 choices. You can raise the flap, you can do without flap also. Then the RVG was taken. You can see how accurate and how we decided the position is exactly the same. And this is a post view of the OPG. We'll also have the CBCT. You can see the CBCT, what we planned on the left and what we executed on the right. This beautifully, the guided surgery flow is digital implantology, with all the implants on right place what we planned. So moving forward, guided surgery, simple, but it's not a brain-free surgery. Always remember, guide kit or a surgical guide is merely a tool in your toolbox. It is nothing else than that. Guided surgery is not step 1 to X procedure. That is not that you drill for the one time and are done. No, boss. Otherwise, assistant would do the surgery. Why will we do? We have to follow the protocol. We have to follow the guided surgery protocols very strictly. Expect error. After all, it's a human-made thing, so we have to expect some error. Mistakes can and do happen. So let's see one case where we have done a mistake in treatment planning, or you can say mistake in guide during the decision, making the decision for the guided surgery. Now you can see a good buccolingual, good amount of huge bone which is there. We can easily place without guide, but as I said, the guide will increase my precision and accuracy of the final result. So I wanted to go ahead with the guided surgery. We convinced the patient for the extra cost we charge for the guided surgery, and patient was convinced. But what happened? We didn't check what? The mouth opening of the patient. there was a limited mouth opening, because in guided surgery, the space we need more for the guide, for the sleeves, for the material of the guide. We need approximately 10 to 15 millimeter extra mouth opening than the routine one. So in this case, we failed to place the implant with the guide. We just threw off the guide and we placed the implant freehandly. Definitely, our implant placement was not at compromise, because bone was good, but otherwise, yes, the problem was the lot of cost the patient, as well as the main thing, the commitment to the patient was false, because we committed them there will be no swelling, there will be nothing, because we are using the most latest technology with the guide, and we failed to do it with the guided surgery. So it directly impacts the psychology of the patient, just because I didn't see the mouth of my patient. In guided surgery, because of all this additional stuff, we need at least up to 40 millimeter of the mouth opening to do a placement of first molar, or at the max second molar. So the operator experience plays an important role here in the accuracy of the implant placement with all the surgical guide. So to guide or not to guide. So we have errors, we have good things, bad things, everything. So whether to guide or not to guide is a big question. So these are the two different conditions where we actually end up. Most of the people will say the condition which is on the right will not do it with the guide, and condition where we on the left will do it with the guide, because there is no bone, there is hardly any bone. But I will tell you, if you are a newcomer, reverse your plan. If you are a newcomer, do the guide surgery where there is ample amount of bone. And with that, you can have more precise and accuracy, because in the left case scenario, if you are going to place even with the guide, and if you fail or something with the guide, if you have some mistake during the surgery, then you are gone. You are finished, because you will be perforating maybe buccal plate, you may damage the bone, hardly any bone is there. So not at the initial cases, but yes, on the later stage, you can do that. So in guided surgery, what are the potential areas of error? So CBCT scan, intraoral representations, planning softwares, computer-aided manufacturing, guide design, clinical factors. So these are the areas of error where right from the first, that is CBCT scan, we heavily check the scanner calibration. Was there any movement during the scan? Voxel size setting was done properly or no? Because when we plan a guided surgery with pterygoid implant, we need a bigger voxel size compared to what we do routinely. Intraoral representation, how far, what impression material you have used, and how soon you have poured it. If you are taken the alginate impression, have you poured it before 12 minutes? No, then there is a chances of synesis, imbibition, distortion of the impressions. If it was done with the scanners, was it done properly without much fluid in the mouth? We'll come to that point later. Planning software interpretation. If incorrect planning was done, you have more buccal placement. You just didn't notice that. Computer aided manufacturing, that is printing versus milling. Printed guides are always at the lower end compared to the mill guide. Post processing methods, how the guides were clean. Is there any stone, material, anything there? These are the problems. Guide design, we already saw 3 types of guide design. Which type we are using, because the accuracy depends on that. Have you used tooth supported, mucosa supported, or bone supported? Clinical factors like anesthesia. Now coming to the important point of the anesthesia. For the implant surgery, most of us, those who are doing implant surgery, we generally give a local anesthesia, right? We don't give blocks, because we need to see if there is any pressure or pain. Then if the block is given, patient won't have any signs or symptoms. But with the local anesthesia, we can easily relate that. But if you are using a guided surgery, anyways, you are not going to damage the neurovascular bundle. That's the first point. Second point is, if you are using a guided surgery and if you have given the infiltration, there will be swelling of the tissue. Now this swelling will not allow the proper fit of the guide. So that's again a thing that we are not supposed to give any local anesthesia. Overheating, we already discussed in detail about the overheating before, and the tissue resiliency is also a important point. So let's keep the things very simple. There are 2 kinds of error. One is the generalized human error, and secondly a mechanical error within a guide. So in that also, human error, we already discussed that what all things can be. But in mechanical error, what is the error? physical act of the drill. When we have the kit coming from the companies, we don't know how much time the sleeves has been used, how much the drills are damaged, because these are the frictional component. These are tend to break. Tolerance of the drills and sleeves, this may break during the surgery, and if it happens during the surgery, yes, we'll have a trouble, or we just have to change ourselves to conventional implantology rather than a guided surgery. Fit of the guides, again we have to check. So all surgical guide work be very similar. What we need is a total drilling length, that is a D, total drilling length. The difference between the implant length and the top of the drill is called offset or the prolongation. There needs to be room for tissue depth, sleeves, and the handles. That is why, that's what I was saying, sometimes we use the open sleeve. Now if you see the grayish color where it is written a master sleeve, what you can have is without a sleeve, on that plastic material of the guide, on the surgical guide, you can have the opening on the lateral side. So when you are planning, just imagine you are planning an implant placement on upper right 7. Okay, so now you can't go because of the mouth opening. Even if there is a sufficient mouth opening, as is the posterior area, what you cannot do is directly go right from the top. So what you can do is you can go right from the buccal aspect of the guide. You can go in and then you can start drilling. So that will save additional 3 to 4 millimeters of your space. So key facts about the mechanical aspects of surgical guide. Potential angulation error is always going to be there for 5 to 15%. Shorter drills always prefer, because they will reduce the chance of the error, because there won't be more wobbling of the drills. Longer implant increases the chance of the deviation. It is directly proportional, and increased distance between the guide sleeve and the bone increases the error. So the bigger the sleeve, the problem will be more. So ideally, most of the companies have the sleeves which is having a length of approximately 4 millimeters. So that is enough. Greater density and irregularity of the bone increases the error. So if there is a greater density, what will happen? We have to do more amount of drilling. More drilling means more damage to the bone, more overheating of the bone. And irregularity, for that I have already explained you to use the flat drill before initiating any pilot drills, so that you are not ending up with the irregularity of the bone. So mechanical error itself represents approximately 62% of the total error of surgical guide. Now imagine if you remove the mechanical error, like if you have your own kit, if you have your own sleeves, then you are reducing those 62% of the error, and definitely the success rate of the guided implant place will be much, much, much higher. Remember, guide surgery is not a brain-free surgery. It's just a tool in a toolbox. I think so. This has repeated the slide. I'm really sorry for that. Mistakes can and do happen. Now let's move forward to our next step. Now, what is the next step? You all are done with the placement correctly with the guide surgery right now. So now let's see, if there was no guide before, what we used to do. Sorry. Now we will move forward with the post-implant placement procedures. That is your second stage, and that is your scanning, impressions, and everything. So let's see a case where you have this is a pre-op. We are planning to place implant on the upper left 6 of the patient. This is the post-op of the patient is with a guide, not with the surgical guide this time, but with the guide, a different guide what we have for the measurements. In Dentium, they are providing this, and this is the final prosthesis of the patient. So let's see how we went ahead. This is the pre-op of the patient. We use this surgical guide. This guide is again a good tool. Only thing is, it is not the digital guide. It is a conventional surgical guide. When we didn't had a guided surgery kit over here with the Dentium, we used to do the surgery with this. After that, that's an ellipse parallel pin for the most accurate position. We took the semilunar incision because the bone buccolingually, it was a good amount of bone was there, so we don't need to reflect the complete flap. We removed, we did the semilunar incision, placed the ellipse parallel pin to guide our placement, and NR line 5009 implant was placed. After placement, as the torque level was really good, we planned to place the healing abutment directly. So once the healing was done, now what we did, what is this? What is this white color tool? That is your scanning abutment, scanning healing abutment. Now this has two purposes. This can be used for the scanning also, that is, it can be used as a scannable abutment, scanning gel, and this can be used as a healing abutment as well. So this is gonna solve my two problems. One is I don't have to use a metal healing abutment. Secondly, I can use it for the scanning also. So why scanner? Now coming to the another part of the digitalization where we have learned the placement of the thing. Now we are planning to go ahead with the impression, which is now completely digitally. That is where digital implantology works. Why we need scanner? The most important thing is it is time efficient. You can scan upper, lower jaw with the bite, everything below 10 minutes, and your data is ready to go. No pouring of the cast, no plaster cast model, no models you have to save in your clinic. So your space is also much more saved. Better communication with the lab. You can communicate with the lab immediately. Like what we do, we scan it, we send it to the lab. The lab person says me within 30 minutes, if it's a crown, if there is an undercut, anything, we can immediately sort the problem, rescan it, and send it to the lab again. So your communication is much better with the lab and much faster with the lab. Better communication with the patient also, because when the patient is coming to you and if you scan it, it can be used as a diagnostic tool. You can see the real-time images in the patient's mouth, and you can show them what all problems lies in the patient intraoral cavity. So that way there is a better communication with the patient. But the question is how to use it. Because over here, the lab person comes with the scanner, they scan and then take away. But what if you have your own scanner? How long this gonna work? Because next 5 years in implant dentistry or in dentistry in India, they are going to change the things that impressions will be out. We'll take the impression only in some cases, very rare cases. Otherwise, a full mouth impression easily can be recorded with the scanner. So when we'll be talking only about the implants, how we are going to use. So when we use the scan guide, there should be always a healed gingiva and it shouldn't be a healing gingiva. Because if you have a lot of blood, if you have a lot of fluid around and surround the site of the scan, there will be a lot of reflection and there will be distortion of the image. And this is how the image looks like when you have the healing gingiva instead of the healed gingiva. With this data, none of the lab will able to produce what you want. So next will be scan body. Now, what is scan body? It is an implant. It is a tool used to scan the position of your implant. So, implant fixture location and path as a marker, that is your scan marker. Always keep this flat side on buccal or the lingual aspect. This is the scan body. Different types of scan bodies are available. Like I showed you that scannable abutment, that is also a scan body. Again, it can be used for the scanning. Even these kind of scan body can be used for the scanning. Everything has the same purpose, nothing else. So what we have to do, we have to check the fit of the scan body, because if the fit of the scan body is not proper, like the abutment position, like the impression coping, when we take the implant impression, open tray, closed tray, whatever, we take the X-ray, right? So when we take the X-ray, we see exact fit of the impression coping in the implant. If there is a problem with that, the final prosthesis will also have a problem, right? The same way, if your scan body hasn't fit properly, then if you have to scan that data and then the final prosthesis come in, then you will have a problem. If the direction of the matching point is towards proximal, what will happen? There is a lot of tooth structure present, and the scanning of that part will be very difficult, because you need to move the scanner at the various angles, and difficult to confirm accurate data since there are teeth on both the sides. So that is why the flat portion, which is showing the direction of the matching point, should always be either buccal or the lingual or palatal. I'll show you the scan, that time you'll understand better. Multiple scan bodies. Again, coming to multiple scan bodies, when you have a two adjacent implant, like in our case, 3637, 4647. Now, if I place the flat and exactly overlapping each other, like if you are keeping both buccal, if I keep both palatal, then it will overlap. The data will overlap with each other, and which is not good. So what we have to do, one buccal, one palatal, one buccal, one lingual, something like this, we have to do it. Scan method according to the scan bodies. So if you don't have a scan body, like if the healing abutment and the scan bodies are separate, so what you should do is you can take out the healing abutment, scan it first, then place the healing abutment and scan again over that, so that the more zenith of your gingiva is accurately scanned on that area, so that you will not have the problems with the emergence profile of your abutment, emergence profile of your crown. So what you can do is take healing abutment off, make sure to scan gingival emergence profile clearly. So it is important information when you manage gingiva pressure of the custom abutment, because with the scanning you are going to go most of the time with the custom abutment only. Next is scan method according to the scans. After implant surgery, immediately you can place the scan body and the healing abutment, and you can do the scan on the same day. So therefore, shape of the healing abutment will come accurately. So there is no problem with that. Moving forward, scan precautions. Yes, there are a lot of precautions we have to take while scanning. The most important which is there is the fluid control. Saliva. We have to dry out the areas. Especially we have to dry out the bubbles, because if there is a bubble, there will be a light over it, right? The light will be coming from the scanner itself, and this bubble will reflect the light. So this won't give you the accurate data. So we have to reduce that. Fluid control, hemostasis, control bleeding. Otherwise, as I showed you, data will be again distorted. So we don't want that distortion, distorted data. So I have a yeah. So moving forward, tissue fluid, that is a healthy gingiva should be there. Tissue fluid pus will make the heart to get the accurate scan data and proper final prosthesis. These are the 3 precautions what we have to take. Coming to retraction, yes, there are 4 things how we can retract. Soft tissue retraction should be there. Finger, mirror, or Optragate. 3 way you can do it. You can practice those things. I usually do it with the mirror right now. I'm comfortable with that. Optragate, fine. Even if we don't do it with Optragate, it's fine too right now. Finger or mirror, one thing, we have to make a habit of ourselves to move the scan along with the finger, so that you record everything. We'll see the scan and you'll understand how it is. Coming to scanner angle, always have your scanner angle at 45 degree when you are scanning lingual or the buccal area. So that makes the ratio 1:1:1. And avoid headlight or the light which is there on the top of the dental chair, because that will distort the data. You can see here the data distortion on the anterior aspect of the tooth. Though we are not worried about that area right now, but if you are scanning that area also for the crown or anything, so we can have the problem during the final fitting of the crown because of the data distortion. So we are not supposed to use that as well. Now moving forward to same case, what we left. We had the scan abutment there, healing abutment, a scannable abutment, and then we sent this design for the CAD, that is your customized abutment, for the manufacture of the customized abutment. So once that is done, the milling of the abutment is done, we have given the temporary crown to the patient. These are all 3 temporary crowns you can see. The premolar and the molar was crown prepped, if you have made the note, and this 3 temporary crowns are given for the rest of the healing period, because this was done after 1 month of the placement. Once that is done, we have taken the shade of the patient. Now here is little bit of challenge, because what abutment you have, the abutment is of the metal, right? So the metal part is not easily recorded by the scanner. So what we do here, we take the impressions and we scan the impression itself, and then plan the designing of the final prosthesis. And this is how all 3 crowns where milling brushing was done. And see, you can see the milled abutment, and the final prosthesis was given to the patient with the access hole, so that retrievability is not a question. This is how my final prosthesis was given to the patient with the tiny access hole. That's the one of the advantage of NR line implants. When I am planning anything with the NR line, it has a very tiny access hole. The abutment screw which is there is very, very small. Though it is strength-wise, it is, but it is very small. So the hole which is coming on the crown is really, really very small. That's the advantage. Moving to another case where we have a failing anterior. Now in this case was little challenging, because the patient was little demanding, where they needed a crown which is very, very accurate to the adjacent tooth. Here is the failing 2-1. So we extracted the tooth. There was a huge fenestration was there. We opened up the flap, we cleaned, curate, we did the drilling part, and we placed the implant with the bone grafting with the osteon 3, osteogenous bone, autogenous plus synthetic bone were mixed, and NR line 3.311 was given. So after that, a collagen membrane, same again with the osteon Janos membrane was used. Once that is done, sutures, yes, good suture material and not practice is necessary. Otherwise, complications do happen. Just a funny picture which I got it from the internet. Once the suturing was done, patient was given A6 retainer in this case because patient was a little fuzzy about the anterior part. We give just for the temporary A6 retainer was given so that patient have something then nothing. And after 2 weeks, you can see the good amount of healing. We waited more, and after 3 months, we saw the site has healed. You can appreciate the buccal architecture of the bone and the tissue. It's amazing. Then post that, we immediately started with the second stage surgery. Again, we did the semilunar incision. Now in this here, if we have done, though in this case it was not done the guided surgery part, but if you have a guide, you can same guide here, and you can have a small incision or a flapless, or you can use the punch to exactly locate the position of the implant. That's another advantage of the guided surgery. Once that was done, we place the healing abutment. Initially, see, we don't stock everything, so you can reuse the things, but we don't use this kind of healing abutment anymore repeatedly. Why? I'll tell you. We buy a healing abutment separate for each and every case. So I'll tell you why also in further slides. Once that is done, now see what we can do here. There won't be sound for this video. So how to scan a scan body in any of the patient. After registering a case for 3.6, we are registering a case where we want to make a titanium custom abutment. And yes, that's the point. That's where you have to click it after scanning. First, we have to scan the maxilla. As we have the mandible for the scanning abutment, we'll first scan the maxilla. We scan the mandible. Now you see we have scanned the mandible without a healing abutment inside. So we have scanned complete gingival emergence. Now over that, we'll put the scanning abutment or healing abutment. Now, this is how the scanning is done with the scanning abutment. Now there, you can see this same way they scan the. Now you can see the flat end which was buccal. As we discussed, the scan part should be buccal. And once the scanning is done, now initially when we used to work with this, we used to do this way. But now there is something called as artificial intelligence which is given to this feature of the Medit scanner. Now this artificial intelligence, what they do, you just have to fill in a data which scan body you are going to use. It will automatically detects the scan body, and it will put their scan body on the top, so that you don't have to scan completely. Why? Because sometimes the interproximal area might be of problem. Let's see how in this video. Now I'm selecting a scan body which I am going to use in my patient with sizes, as they have their own library. I've assigned what I'm going to use with the system, company, everything. So now I'll start scanning. Selected, I've assigned. Now I'll start. See, there is things from the library. The scan body is already there. As soon as this, now this automatically detects it and it will come on the top. Now you can see that, and that everything is in green now. That means it has the maximum accurate data. See one more time. Flat end was matched. If you don't do it, if it doesn't happen, so you can this way also. You can just select the points and you can have. So now you don't need. So what happens in with this? You don't need to scan it completely. And if you are not comfortable with the initial stage of your scanning, you can use this artificial intelligence feature of the scanner and and record it with the perfection. Now healing 1 day after second stage surgery of the same case, we have placed the scannable abutment itself. We scanned it because as it was the anterior case, we were planning to give something at least after 2 months for the temporary after the S6 retainer. So we plan to give the temporary abutment, temporary crowns over it. So we customize the abutment. Once we have customized in lab, once that is done, this is a customized abutment from the lab. These are the pre-milled abutments which are customized. That's what we called UCLA. So now when we are doing an anterior case, whenever I'm doing an anterior case, I always like to anodize my abutment. What is anodization? Basically, it's a process which increases the thickness of the natural oxide layer on the surface of the metal parts, which makes the abutment more of the yellow color. Now, most of the people using, now I can have a different yellow color also. It's like I can have the more yellow, I can have the less yellow. I'll show you how it is done. So why we need this yellow color? Because we need some like metal part which is a grayish in color. Sometimes pop up from the some gray part seen on the gingiva. So that some patient doesn't like it. So we can make it yellow. It matches to the gingiva color a bit, and you can have the more better outcome of the prosthesis. So you're seeing many of the implants also have the markings over it. So that is actually done with the anodization process. Like Noble Biocare has all the components. Even the implant top is pink in color if you have a pink series of the implant. Implant is yellow top with the yellow series of implant. Now recently some blue color implant has also come. See, basically the titanium is grayish in color. So this anodization process helps out with this. Now what is anodization? It is a self-limiting increase in thickness of the titanium oxide layer. It is not titanium nitride, okay? Titanium nitride, which was there TIN, sorry, it is not biocompatible, but titanium oxide layer is a biocompatible and layer. It increases the thickness chemically and biocompatibility remain the same. Oxide layer thickness depend upon voltage used. You can change. That's what the oxide layer, more the thicker, more yellowish. So you can have the oxide layer thickness depending upon the voltage used. Colors can be produced by light interference patterns and reversibly by polishing. If you polish it, it will go back to its natural color. So these many colors you can have on your abutment, on your implant, anything you can do it. Initially, how it was invented, like it was much years back. It was actually used for the keratoprosthesis. Now some people have a different color of eyes, right? Different eyes color with the different structure inside. Multiple color eyes also there. So they used to have this kind of keratoprosthesis, artificial cornea they used to create to look it more beautiful, to look it more natural. And from there, we took out the concept of anodizing the titanium surface. So these are the 50 shades of the titanium which we can go, but not the gray. It's not a 50 shades of the gray. This color can be used for the component also. Now you can see the most extreme right implant diagram, which is of the Noble Replace Select implant. Here you can see the internal is also yellow, above also is yellow. So this is all done with the anodization of the titanium material, and it is 100% biocompatible. These are the different colors what you can have with the anodization and that. So if you anodize it for the 10 volts, for say 60 volts for 10 seconds, you can have a lighter yellow. 60 volts, 85 volts with the 10 seconds, you can have more pinkish type color. So this is how it is. More voltage introduced, more different colors you can have. That is about just some part of the anodization, which I always like to do it. So the abutment level studies have shown that an oxidized nanostructure surface stimulates more gingival fibroblast adhesion than the machine surface. An oxidized surface enables more epithelial cell attachment than a machine surface, and reduced surface roughness at the abutment can decrease the plaque accumulation also. So these are the three advantages what I can say to do the anodization of the surface. This is how we anodize the abutment and given the temporary. Though the access hole was coming little buckly, as it was a temporary crown, patient didn't have any problems with that. So once that was done, some healing was again we waited for some time to heal. Shade was taken, and now we scan the abutment. What final abutment? Because scan here in the last case I showed you, we took the impression. Here we tried to scan it. So with the scan you can have the data accurate, but little bit of compromise is there. You can see there is a darkness of the abutment, but still it is a workable model. The data is sufficient so that we can proceed with the cases, and then we give it to the CAD design, milling, and the final crown was after the finishing. The final crown had come, and this is what my final crown looks like. Because there was some cement during the temporary, there is some inflamed area on the top of the cervical margin of the crown, but this will heal on its own, and it is actually healed. We are not so much worried about the anterior tangle which is there, and is fine with that. Moving to the next case, where we had started the case in 2014, finished in 2020. 2014, finished in 2017. So what happened in this case? It was the case of the partial anodontia, and that time I didn't have a DSLR camera, so the photograph was like that. So we created the space with the help of the orthodontist, that how we are going to. In this case, we actually did it one side guided and one side without a guide, because we wanted to evaluate the things. So how? So in 2015 we did a surgery. Right, the left side was done without a guide. Flap was taken in papilla preservation flap. A small flap was raised, and the drilling was done with again a NR line. I'm little bit happy with the NR line results, so I'm using more of the NR line implant in Dentium. And this is a placement of 3011. 30 is the diameter, 11 is the length of the implant. On the other side, we prepared a guide with the sleeve. We used the guided kit. This was the planning done. There was sufficient bone. So we used the Densa burr also in between to expand the bone little bit. We did the final placement with the guide itself. See here, as I showed you before, I'm just reversing the image. Yeah, so there was a sleeve. It was planned. But what happened during the trying process, this portion of you can see some portion of the incisor is popping out. Now that created a problem during the fitting of the guide. That time we removed the sleeve and we did the surgery. Surgery was good. It was, and 3011 again the space was same. We placed the implant and immediately patient was given a Maryland bridge, which we did it with the scan. Because we scanned it edentulous for the guide beforehand, our this thing was ready before our surgery. Our this Maryland bridge was ready before our surgery was commencing. So that was the good part about the surgery, about the scanning, that we have everything well before. This extra extension was then trimmed off later on, and this is how the patient went from the clinic post surgery. He was happy. He was called 3 months back. Then we did a second stage surgery. You can see nice amount of healing on both the sides, good papilla, everything looks good. Now this is the area where we did a guided surgery. So you can appreciate the interdistance from the tooth, the implant position and everything. And this we did it with free hand. Despite taking a lot of care, despite doing a lot of surgery, you can see that it has moved a little bit on the distal aspect of the distal towards the canine. So that is what the importance of guided surgery. Here the precision is there, but accuracy is not there. But there the precision and accuracy both is there. Then this is a scan with the scan abutment. As I showed you in the previous video, how do we scan the scan abutment? Data was sent, milled abutment was called, a milled abutment was given to me, and then we give the final prosthesis to the patient. You can appreciate patient was happy. Little bit of proclination is there, but patient is fine with that, so we don't have to worry much about that part. Coming to second last case for today, we did a lower anterior. Lower anterior, again, we did scanning. This is the poster of the patient with the 4 implant placed. You can see nice parallelism because of the guided surgical placement. We get such kind of parallelism. Freehand, little difficult. I will not deny that it will not happen with you, but yes, little difficult with the free surgery. This is how we planned. Only 4 implants were planned. We guide, but here we went only template assisted guide surgery. That is, we did only pilot drilling because it was the lower anterior. There was some grafting was required. We just wanted the initial position of the implant. So we did a template assisted guided surgery. It is not a fully guided osteotomy. We did the pilot drilling and then remove the guide, open up the flap, and then proceed with the placement and the further drilling of the osteotomy. So this is how it is. So you can see the holes which are there. They are very tiny. It is only for the pilot drilling. So once that is done, see, we had opened up the flat. We did some grafting because the bone was really thin here. But we wanted an accurate position of the implant because it's the lower anterior region. So we placed the 4 implant. You can appreciate the parallelism of the implant. Then the collagen membrane and everything was done correctly, and the suturing was done. Post that, waited for the healing. We gave the healing abutment. Some hygiene maintenance was always compromised with the patient. We have given the 4 healing abutments, and that we proceed with the scannable abutment. We change it to the scannable abutment, and we scan the data. As my protocol always is that I am going to give temporary prosthesis, so that's okay. Even if there is some healing issues initially stage, there is no problem with that. So all the abutments, CAD designing with the customized abutment. Now, as it is a lower anterior, again, I'm not much worried about the grayish part which is going to seen. That's fine. So I don't need to anodize. Even if you do it, that's not a problem. But here, I'm just saying that I've not done it. So these 4 milled abutment are ready to go, and we placed it with temporary crown with provisional restoration, waited for the healing more, took the shade, and the final crown were given. Here we again take, because scanning for this thing was going to be a task. So we, instead of that, we took an impression of the abutment itself, pour the models, scan the models, and then proceed for the crowns, CAD designing, and the final prosthesis of the crown, and the finishing was done. Here we could have used the, you can say, some like FP3 prosthesis, like some soft tissue replacement with the pink ceramics. But technician was, I don't know why they didn't do it, and I also forgot that time that why we have not done that. And patient was also fine, so that's okay. But we had a good results with the case. Patient was happy, good healed gingiva everywhere, and good healing with the good bone formation, buccolingually. So we are not worried much about the prosthesis now. So the digital impressions always have the full benefit. Digitalization always have the full benefit. That is, you can have a digital impression, you can have photos, you can make aligners, you can have a DSD, that is digital smile designing, you can have a digital mock-up, and a new permanent smile, a small case, not of the implant, only 2-3 slides more, where you can see this lady came with the smile, where she was not happy with the smile because of some proclination. You can see the central incisor discrepancy. One is smaller, one is longer, and lateral one is proclined, one is not, one is one above another, like that. So we planned her for the digitalization. How the crown, how the position of the tooth are. Post that, we gave her a mock-up immediately with the DTS software, that is digital treatment simulation, and with the photograph, we told her, see, you look like that. She was really happy with what we can give her, and yes, we commenced the procedure with some crown preps, veneer preps, and everything. And finally, we gave her a smile, which is completely digitally designed. So I don't do much of these things, but yes, digital impressions and the digitalization has given the tremendous benefits to our patient as well as to ourselves in execution of the treatment planning. And this is the final smile of the patient, where she's very happy with the smile what she had and now what she has. Very happy with this present smile. So to end up the lecture, as I committed, there will be more smart sentences which is given by very smart people on the earth. Thomas Watson, IBM president in 1943, said the world market could be able to absorb not more than 5 computers. Shocker for every one of us. Also said there is no reason for someone to have a computer at home. Now everybody has more than 2 or 3 computers at home itself. He was a life member of Emirates of MIT Corporation and are very well known. Bill Gates in 1981, not so far, 1981, he said 640 KB should be sufficient for every person. We have minimum phone which is having a 64 GB storage, and which is also sometimes says your data is full, kindly empty your space. So what are the limitations of digitalization? The only limit of digital technology is our imaginations. And that is what I want to say, and I would like to thank you everyone. Thank you, Dr. Ajit, to giving an opportunity to speak. Digital impression works for whatever I have tested till now. Just do it. It's a quality versus price. Name something I can't do, and I'll definitely give a try. Like I'm trying to do the things on the full mouth rehab cases right now, which we have not got so much success, but yes, we are doing it. And I guess what we see here is just the start, right? It's only a 50 years of implant dentistry and digital smile designing and everything, hardly 10 years. So it is just the start. It's all in a baby stage right now. Once they will be in adult stage, I think so many good things we can do. To end up my lecture, I would request everyone to donate some to PM Cares Fund. We are going through really a tough phase. Everybody knows it. We have to fight against this COVID-19. We have to stay home, stay safe. We have done it yesterday. I request all of you to donate some amount of donation, not more than you can do a little things. Also, there's no problem in that. And thank you very much to listening me carefully. Well, thank you, Dr. Wajid, that we can start with the question answer series if we have.
Sir, let's start the question answer session right now only.
So, how we are
Whoever
going to start that live?
has any question regarding this whole seminar, you can ask in the comment section. Dr. Kenal will reply you by voice. So whoever has any question regarding anything, you can ask Dr. Kenal sir. Thank you.
हाँ sir. Yeah, but how am I supposed to do that? Thank you. Okay. Am I audible? Yeah. So the question to answer to Dr. Prasad is: I'm a beginner. Which camera and scanner do you suggest? So depends. Camera, DSLR, anything is fine. Canon, Nikon, anything is fine. What I'm using right now is the Canon 700D. But important is you have to use the 100 mm macro lens to have the good photography. And scanner, if it's as a beginner, I will suggest you can call a lab person with the scanner, start doing that, and then post. Once you are comfortable with the scanning, you can buy a scanner. I am using a Medit scanner right now. Reason one most important reason for the Medit scanner is I don't have it's not so expensive. Definitely it is, but compared to other scanners, it is costing us around 10 to 12 lakh rupees right now. And apart from that, there is no yearly subscription which is there in the different systems. So that is the important. Answer to Dr. Sachin Modi. First of all, thank you so much for the comments. If your fit is not perfect, as you mentioned, and if you lose some amount of bone, sir, if the fit is not perfect on the initial stage only, then I will not start only osteotomy. So what we will be doing is we have these scans, so we will not lose the bone, because if the fit of the guide is not properly fitting on the patient's cavity, just keep it aside and we'll do it. Yeah, so this page has this many, and I think so there's one more page where we have comments. So I think so questions. Let's see if there are any comments and questions. Okay. No, it's about that. So anything else? I think so only two questions are there till now. Why new howling? Yes. So I missed that part. Yeah. So yeah. So why we have? So what do you do? What do you do with the healing abutment? Can you tell me? If I am not wrong, most people what they do, they just clean the healing abutment. So the study has shown that even if you clean your healing abutment thoroughly, even if you autoclave it, now give it to your lab to test for the protein. So there will be some protein always lying on that, always some protein is lying on that healing abutment itself. So there are chances of contamination with the healing abutment. So that's the new study which has come almost 3 years back. So we have stopped using the healing abutment, rather than we order a new healing abutment for each and every patient. So we are not able to clean it everything. So Sachin sir is asking, how do you come to know about the error of CBCT? Yeah, so about the error of the CBCT, we have to see the things clinically, because many times as you are doing a regular implant surgeries, you know that sometimes it is written on that there is a 9 mm or 10 mm of distance from the sinus, but while drilling, sometimes it's only 8 mm or sometimes it is more than 9 millimeters, right? So in that, what we have to ask our CBCT machine where we are sending is that have you calibrated the machine? What is the voxel size? These are the normal questionnaire which you can ask them. Like we have a CBCT center over here with the Dr. Vinayak, and always have a conversation with that. So that way you can have the error of the CBCT, and most important, calibration of the CBCT. The person from the company should always come and calibrate the CBCT as per the guideline. Like in the scanner, to maintain the accuracy, they have given the calibrator to the person who is purchasing the scan itself. So every 15 days we have to calibrate like that. So I think so. No more questions. So yeah, there is one more. CBCT is usually not available every time. What may be the alternatives to avoid errors in planning? So, Dr. Imran, Nahid Imran, yeah, what I'll suggest you, if you don't have a CBCT always, then at least take the 3D model of the patient, like a normal alginate impression. Do the sounding test of the bone, like how thickness is there for the gingiva thickness, how is the biotype of the gingiva. Apart from that, you can make a normal RPD, at least a removable partial denture. You can have the access hole from there, so that you are at least prosthetically you are at the correct position. Then drill it from the top, and after the initial drill, open up the flap. So even if you are little buccal or little lingual, you will come to know to correct the position. That's the only way which we used to do beforehand, before the CBCT. Still, if you all have any questions, I'm writing my email address over here. You can mail me the queries, not a problem. Also, I'm putting up my mobile number where you can call me up. You can WhatsApp me the queries. There's no problem. Anyways, it's a lockdown time. We are totally free. So we can have more discussions on that part. I think so, Doctor. We shall end our lecture here.
Yeah, sure, sir. We will end our lecture here. And whoever has any question, anything regarding here, you can also comment on this sections. Whenever you will see it is in the library of
I
this
think so,
page, you can see whenever you wish to. And yeah, sure, sir. We will end our lecture here. And whoever has any question, anything regarding here, you can also comment on the sections. Whenever you will see is in the library of this page, you can see whenever you wish to. And yeah, sure, sir. We will end our lecture here. And whoever has any question, anything regarding here, you can also comment on. Thank you everybody for present be here, and sorry for the interruption. It's kind of network issue we have faced, and hope it is fine and you have learned something from us. Thank you so much. Thank you, Kenal sir, Sachin sir, who is always there my back, and Dr. Brijesh sir and Dr. Sandeep sir for presenting past lectures. Thank you. Tomorrow we have again live sessions with Dr. Nigam Booth sir about the implant prosthodontics. He is a MDS prosthodontist from Rajkot, and speaker for OSTEAM also. So stay tuned, stay healthy, stay happy, stay home, and stay safe. Thank you very much, and stay updated. Thank you very much for everyone for being here. Thank you so much to give us this chance. Okay, now we are ending our sessions. Thank you.
Thank you, sir.